Good morning, everyone. This is April 5th, and it's the time for Orlando GI General Club. Welcome, everyone. So our first study today is a study looking at rifaximin for liver fibrosis in patients with alcohol-related liver disease. This is the randomized, double-blind, placebo-controlled phase 2 trial published in JAMA. Alcohol is the leading cause of liver-related mortality worldwide, and fibrosis is the most important predictor of liver-related complications in alcohol-related liver disease. Only available treatment for liver fibrosis in alcohol-related liver disease is alcohol rehabilitation. However, episodic relapse is common. Rifaximin is a broad-spectrum bactericidal, non-absorbable derivative of rifampicin and used to treat recurrent hepatic encephalopathy. It modulates gut microbiome and promotes gut barrier repair in decompensated cirrhosis. The aim of this randomized trial was to investigate the efficacy and safety of 18 months of treatment with rifaximin on liver fibrosis in patients with biopsy-confirmed alcohol-related liver disease. So this was a single-center, randomized, double-blind, placebo-controlled phase 2 trial conducted in Denmark from March 2015 to November 2021. They included all adults aged between 18 and 75 years of age with history of current or previous alcohol overuse and who had a biopsy-proven alcohol-related liver disease with no previous hepatic decompensation. And patients were randomized in a one-to-one fashion to oral rifaximin versus placebo for 18 months. And the primary outcome was to look at the histological decrease of at least one fibrosis stage after 18-month treatment on end-of-trial biopsy. So in this study, 68 patients were randomized to the rifaximin group and 68 patients to the placebo group. And a good proportion of patients had coexisting underlying medical conditions, including diabetes, hypertension, hypertriglyceridemia, and low HDL. As you can see here, the liver fibrosis stage of all stages were included in this randomized trial. The most common fibrosis stage being fibrosis stage 2, followed by stage 1, although there were 6% and 3% of patients with the most advanced fibrosis stage in the rifaximin and placebo groups, respectively. When looking at the histological endpoint, they found that when looking at the regression of fibrosis, this was achieved in 26% in the rifaximin group and 28% in the placebo group, and there was no statistical significant difference between rifaximin and placebo. However, when looking at progression of fibrosis, they found that this happened in 24% of rifaximin group compared to 43% of placebo group, and this was statistically significant with p-value of 0.044. When looking at hepatic lobular inflammation and hepatic steatosis, they found that there was no significant difference between rifaximin and placebo for both regression and progression of both hepatic lobular inflammation and hepatic steatosis. When they examined the adverse events, the overall adverse event rates was 71% in rifaximin versus 78% in the placebo group. And when they looked at serious adverse events, it was 21% in the rifaximin group versus 18% in the placebo group. And serious adverse events included gastrointestinal disorders, musculoskeletal connective tissue disorders, and liver-related events. The limitation of this randomized trial was that patients with a wide range of liver fibrosis severity were included in the study. However, the therapeutic goal should perhaps be different depending on the severity of liver fibrosis. And all patients were of white ethnicity. This was conducted in Denmark, and thus limiting generalizability of the results to patients of different racial and ethnic groups. The take-home point of this randomized trial is that in patients with biopsy-confirmed alcohol-related liver disease, 18 months of treatment, rifaximin did not promote regression of liver fibrosis. However, rifaximin appeared to reduce progression of fibrosis. Therefore, rifaximin appears to decrease progression of liver fibrosis in patients with alcohol-related liver disease, and therefore might be beneficial for individuals who cannot achieve alcohol abstinence. Our next randomized trial is from New England Journal of Medicine this month, looking at vedolizumab for the treatment of chronic pouchitis. Restorative proctocolectomy with ileal pouch anal anastomosis, also known as IPAA, is routinely performed in patients with ulcerative colitis undergoing colectomy. Pouchitis, which is idiopathic inflammation of the pouch, is the most common long-term complication of IPAA. It develops in around 50% of patients within 5 years after IPAA and recurs in less than 50% of affected patients. Chronic pouchitis is when symptom duration of 4 weeks occurs in approximately one-fifth of patients. Vedolizumab is a monoclonal antibody approved for treatment of moderately to severely active ulcerative colitis or Crohn's, and may be effective in chronic pouchitis as lymphocyte infiltration is a characteristic of an inflamed pouch. The aim of this randomized trial was to evaluate the efficacy of vedolizumab in the treatment of chronic pouchitis after IPAA for ulcerative colitis. This was a phase 4 double-blind randomized trial. Patients with chronic pouchitis after IPAA in UC patients were included and were randomized in a 1-to-1 fashion to either vedolizumab or placebo. The vedolizumab dosage was 300 milligrams IV given on day 1, and then other doses given at weeks 2, 6, 14, 22, and 30. And concomitant ciprofloxacin from weeks 1 to 4 was also administered. The primary outcome measure was the remission per modified pouchitis disease activity index, defined a score of 4 or less, a reduction from baseline of at least 2 points in the modified pouchitis disease activity index total score. 51 patients were randomized to vedolizumab and then 51 patients to placebo. The median ages of 42 in vedolizumab and 45 in the placebo group. When looking at the concomitant use of antibiotics immediately before. Study enrollment was 57% in vedolizumab compared to 49% in the placebo group. The PDAI score was mean of 10.5 in the vedolizumab and placebo groups. The use of a TNF antagonist after colectomy was as follows. TNF antagonists were not used in 71% of vedolizumab versus 74% of the placebo groups. When looking at the primary outcome measure of looking at disease activity according to the modified pouchitis disease activity index, they found that the percentage of patients who had disease remission was 31% in the vedolizumab group compared to 10% in the placebo group, And this difference was statistically significant with a p-value of 0.01. Again, remission in this study was defined as the modified Pouchitis disease activity index score of 4 or less, and reductions from baseline of at least 2 in the total score. Adverse events was follows, was encountered in the majority of patients enrolled in the study, 92% in the vedolizumab and 86% in the placebo group. When looking at adverse events assessed by investigators as being related to vedolizumab or placebo, this is 24% in the vedolizumab group and 22% in the placebo group. The serious adverse event rate was 6 and 8% in the vedolizumab versus placebo group, and included the recurrence of Pouchitis, gastroenteritis, seen in the vedolizumab group, but this again was seen in the placebo group also. The limitation of this randomized trial is that concomitant antibiotic use after 4 weeks was reported in a high percentage of patients in the vedolizumab group, and the study follow-up in this randomized trial was 34 weeks only, and therefore longer assessment of the efficacy and safety of vedolizumab is warranted. The take-home point from this randomized trial is that among patients with chronic Pouchitis after undergoing IPAA for ulcerative colitis, treatment with vedolizumab was more effective than placebo in the induction of remission. Our next randomized trial, our next study is published in JAMA, is looking at the association of life expectancy with surveillance colonoscopy findings and follow-up recommendations in older adults. Surveillance after prior colon polyps is the most frequent indication for colonoscopy in older adults. However, current use of surveillance colonoscopy clinical outcomes and follow-up recommendations in association with life expectancy have not been studied. The aim of this study was to evaluate the association of the estimated life expectancy with surveillance colonoscopy findings and follow-up recommendations among older adults. This was a registry-based cohort study using data from the New Hampshire Colonoscopy Registry linked with Medicare claims data. The authors included all adults above the age of 65 who underwent colonoscopy for surveillance after prior polyps between 2009 and 2019. The primary outcome measure was to look at the clinical findings of colon polyps or colorectal cancer and then make recommendations for future colonoscopy. A total of 9,831 patients were identified for inclusion in this study. And as you can see, the majority of patients were aged between 66 and 74 years old. The next common age group was 75 to 79 years of age, and there were 1.9% of the study cohort comprised of patients of 85 years or older. The female-male split was fairly even, 46% female, 53% male. And the majority of patients in this study were white. Expected life expectancy was less than 5 years in 7.5% of the study cohort, and 90.1% of the patients in the cohort was able to undergo a complete colonoscopy. In terms of health status, when looking at self-reported health, 12.2% reported excellent health. However, 0.6% reported poor health, and 6.7% of the study cohort had self-reported fair health. So when they looked at surveillance colonoscopy findings among these older adults over the age of 65 years, according to life expectancy at the time of colonoscopy, when they looked at the colonoscopy findings, there was no significant findings in 5,355 of the study patients. And when looking at those with at least 10 years of life expectancy, they found no significant findings in 57.2% of these patients. And in patients with less than 5 years of life expectancy, they found no significant findings in 46.3% of these patients. When looking at patients with detection of at least 3 adenomas or cyst ulcerative polyps, advanced polyps, or colorectal cancer, these findings were in 14.9% of patients with at least 10 years of life expectancy and 22.9% of patients with less than 5 years of life expectancy. And this is a graph looking at the percentage of adults with recommendations to continue colonoscopy surveillance. So again, they looked at the proportion of patients with patients in the study cohort who were recommended to have another colonoscopy, a follow colonoscopy after the colonoscopy that they examined for the study in the study. And they again divided this into 3 groups, those with no significant findings, non-advanced polyps, and multiple advanced polyps or colorectal cancer. And as you can see, the patients with at least 10 years of life expectancy were requested to undergo repeat colonoscopy. The patients with less than 5 years of life expectancy were recommended least frequently to undergo repeat colonoscopy. However, patients who had, we're looking at the individual bars here according to their life expectancy. The more advanced your colonoscopy findings, the more likely you were to be asked to undergo surveillance. And that applied to patients with at least 10 years of life expectancy and those with 5 to 10 years of life expectancy. The limitation of this study is that this is a study where they were not able to account for other potentially important factors in decision-making about continued colonoscopy in older adults, for example, cognitive impairment and frailty. Study cohort was compared to patients attending surveillance colonoscopy for selection bias, and therefore selection bias is possible. The take-home point in the study is that the likelihood of finding advanced polyps or colorectal cancer on surveillance colonoscopy was low, regardless of life expectancy, and recommendations for future colonoscopy decreased as life expectancy decreased, but more than 86% of patients in the study were recommended to return across all categories of colonoscopy findings and life expectancy, and 8.1% of older adults with less than 5 years life expectancy were recommended to return for future surveillance colonoscopy. Our last study is a randomized trial looking at the efficacy of POEM versus rheumatic dilation as treatment of patients with achalasia suffering from persistent or recurrent symptoms after laparoscopic Heller's myotomy. For achalasia patients with persistent or recurrent symptoms after laparoscopic Heller's myotomy, optimal treatment strategy remains controversial, and rescue therapy includes rheumatic dilation, POEM, revisional laparoscopic Heller's myotomy, and esophagectomy as a last resort. And over the past decade, POEM has gained acceptance as an endoscopic alternative to laparoscopic Heller's myotomy for primary treatment of achalasia. So this randomized trial aimed to compare POEM and pneumatic dilation in patients with persistent or recurrent symptoms after laparoscopic Heller's myotomy. This was a randomized trial conducted in 3 centers in Europe, and a study was conducted between 2014 to 2020. They included patients from 18 to 80 years of age with persistent or recurrent symptoms after laparoscopic Heller's myotomy. And they defined persistent or recurrent symptoms as Eckhart score of less than 3, with significant stasis seen on timed barium softgram after 2 minutes. Randomized 1-to-1 ratio to POEM versus pneumatic dilation was performed, and with pneumatic dilation group, a graded dilation approach was utilized in the study, which means that all patients were first dilated using 30mm balloons. And then if symptoms persisted, this was followed 1 to 3 weeks later using a larger balloon of 35mm size, and then a 40mm balloon 3 months later if needed. Follow-up was 1 year after initial treatment. The primary outcome measure was treatment success, defined as Eckart's score. Eckart's score of 3 or less without unscheduled retreatment. 45 patients were enrolled in the POEM group and 45 patients in the pneumatic dilation group. When looking at the median Eckart's score, it was 6 in both groups. The majority of patients were type 2 achalasia. When looking at the overall treatment success, which was the primary outcome in this study, at 1 year follow-up, overall treatment success was 62% in the POEM group versus 26.7% in the pneumatic dilation group. And this difference was statistically significant with p-value of 0.001. This means that when looking at relative risk, that if you have a POEM compared to pneumatic dilation, you are 2.3 times more likely to have treatment success at 1 year. We're looking at the secondary outcome measures of the Eckart's score. This also was significantly lower in POEM compared to pneumatic dilation at the end of follow-up. And across the board, POEM was superior to pneumatic dilation, including the LES pressure, barium height at 2 minutes, barium height at 5 minutes. And when looking at the occurrence reflux, this occurred in with reflux with esophagitis occurred in 34% of POEM patients compared to 15% of pneumatic dilation. And although numerically it was higher in POEM, this difference was not statistically significant with p-value of 0.062. The limitation of this randomized trial is that at 1 year follow-up, this follow-up duration does not indicate what would happen with longer treatments, with longer follow-up duration, and so the longer treatment success rates are not known. There is also lack of blinding to the treatment location, and the study compared multiple pneumatic dilations compared to a single session of POEM. However, this was conducted, this methodology was chosen by the authors accordingly to optimally reflect routine clinical care. So the take-home point is that among patients with achalasia experiencing persistent or recurrent symptoms after laparoscopic Heller's myotomy, POEM resulted in a significantly higher success rate than pneumatic dilation, with a numerically higher but not statistically significant instance of grade A or B reflux esophagitis. These findings support consideration of POEM as the initial treatment option for patients with achalasia experiencing persistent or recurrent symptoms after laparoscopic Heller's myotomy. So this is the recap for Journal Club this month. Patients with biopsy-confirmed alcohol-related liver disease. 18 months of treatment with rifaximin did not promote regression of liver fibrosis. However, rifaximin did appear to reduce progression of fibrosis. Therefore, rifaximin appears to decrease progression of liver fibrosis in patients with alcohol-related liver disease and might be beneficial for individuals who cannot achieve alcohol abstinence. Among patients with chronic pouchitis after undergoing IPAA for ulcerative colitis, treatment with vedolizumab was more effective than placebo in the induction of remission. The likelihood of finding advanced polyps or colorectal cancer on surveillance colonoscopy was low, regardless of life expectancy, and recommendations of a future colonoscopy decreased as life expectancy decreased, but more than 86% of patients in the study were recommended to return across all categories of colonoscopy findings, and life expectancy. And 58% of older patients with less than 5 years of life expectancy were recommended to return for future surveillance colonoscopy. Among patients with achalasia experiencing persistent or recurrent symptoms after laparoscopic Hellas myotomy, PERIM resulted in a significantly higher success rate than pneumatic dilation, with a numerically but not statistically significantly higher incidence of grade A or B reflux esophagitis. Therefore, these findings support consideration of PERIM as the initial treatment option for patients with achalasia experiencing persistent or recurrent symptoms after laparoscopic Hellas myotomy. Thank you so much for joining us this morning. Our next monthly GI Journal Club will be the first Wednesday of May, May 3rd, 2023, just before DDW. I hope to see everyone in DDW if you're coming. And thank you so much for joining us today. Thank you. Please have a wonderful month. Goodbye.